The next speaker will be Gudrun Schleiermacher from the Institute Gudrun, who's a pediatric oncologist and a very active clinical researcher as well, leading SciPen biology, ITC biology, active member, INRG biology, and last but not least, the incoming president for the ANR. So a lot of work, and besides that, also a huge amount of research on new biomarkers in neuroblastoma. So she'll be talking on that.
Well, thank you for that introduction, Jan. And after the announcement of Kate about the gala dinner, I try to catch your attention. I would like to highlight a bit more in detail the challenges, the possibilities that we face when we try to link all our genomic studies with the challenges of treatment stratification and adaptation of treatment intensity in this fascinating disease of neuroblastoma. So we've already heard several times this morning that in neuroblastoma, in fact, we're faced with a disease where treatment can go from observation only to the most intensive treatment we can imagine today, ranging from chemotherapy all through to high-dose chemotherapy, immunotherapy, maintenance treatment, etc. And with all this, we know that there has been improvement in event-free survival for all patients over the last decades. However, when we look in detail, this increase in survival mainly concerns, in fact, patients with low and intermediate risk disease. And we know that in high-risk disease, we have a lot of more efforts to make so that we can really increase survival for these patients also. So there has been so much effort put into the identification of biomarkers to fine-tune treatment and to look for new predictive biomarkers to adapt to treatment. And of course, as already mentioned, and if you weren't asleep during Jan's talk, you will have heard about MICN. We know that this is really a long history of biomarkers, and probably MICN, the importance of this is that that was the first biomarker that was really integrated into clinical protocols in pediatric oncology following the discovery of this by Garrett and Manfred Schwab in the 1980s. The importance of this is also that this highlights the challenges of integrating a marker that initially probably was studied also in research labs, and the importance of integrating quality control as we include biomarkers into a clinical setting to have robust data that can be shared through different labs in a meaningful manner. So we know MICN amplification, that is really an important biomarker, especially in non-high-risk disease, as published based on the data sets of the big INRG. And as we already heard this morning, the INRG is in fact a really important data set based initially on over 8,800 patients and looking at different clinical and biological and pathological markers to define pre-treatment risk groups. Now, I don't think we all need to know that table by heart and be able to reproduce it by heart as we leave this room, but I think what is really important is to know what are the markers that are taken into account when we define these pre-treatment risk groups, age and stage, of course, the histological components, MICN, and with regards to genomics data, when this was first published 10 years ago, the reason why there's only 11q on the table is that simply at that time in the INRG data, there was mainly 11q and 1p LOH data that was available, but very rapidly new data has come along, and we have now really indications of the possibility of integrating copy number profile in general into this risk stratification. So as you already heard this morning, there are a number of somatic genetic alterations in neuroblastoma that can really be classified into copy number alterations versus mutations. And these copy number alterations that can be looked at in terms of alterations regarding chromosome segments, and past work that had shown that many of these alterations that occur recurrently, such as 1p deletion or 11q deletion, are in fact of prognostic impact in a univariate setting. making. More recently, the advent of array-CGH techniques then enabled to investigate these alterations in a complete setting, looking at all the alterations in one step. And you already heard about these studies that looked at array-CGH profiles in big cohorts of patients. And what we and others had shown is that you can clearly distinguish different profiles. And the most important aspects of these is that you can have profiles where you have whole chromosome gains and losses. And these patients really fare well as compared to patients whose tumors present segmental chromosome alterations with or without MICN amplification, and these patients do worse. And this could also be shown in the INRG database. Again, as already stated, in the INRG database, we mainly had 1p and 11q data. But when we infer segmental chromosome alterations, or rather the ones that do not have segmental chromosome alterations, those that did not have any of these alterations, we could in fact identify the similar impact on survival when looking at these overall copy number profiles. So in the next steps of this talk, I would like to, as in previous talks, first focus on low and intermediate risk disease and then high risk disease. And in low and intermediate risk disease, think about how we can think about treatment decisions based on these prognostic factors. And we had thought that the array-CGH profile would be of importance, especially in infants with neuroblastoma. And in a European study, we had looked at the array-CGH profile in patients aged less than 1 year with localized unresectable, I keep doing this in the wrong way, or stage 4S or stage 4 disease. And we could see that segmental chromosome alterations occur in 10, 20, and nearly 50% of these different populations. And in these infants, the array-CGH profile is of prognostic impact. And as already mentioned, the logical step to that is then integration of this into an overall treatment strategy. In Europe, we currently have the LINUS protocol that is led by Adela in Spain, and in which we take into account the array-CGH for adaptation of treatment intensity in patients, especially with low-risk disease. So there's a challenge inherent to that, which is the work on different platforms in the biology group and the review of data that is currently being done in a centralized manner. And I think that as we integrate new biomarkers into clinical decision-making, the review of data to a certain quality control is really something that is crucially important, so that we know that what we're talking about and so that we have homogeneous results throughout our cohorts. And so what we have defined as profiles, again, is the numerical profiles, the segmental profiles, and then we also have a population of patients where we cannot conclude. We have profiles where either the technique failed or there was simply a sample that was not sufficient for analysis, or profiles that we cannot classify in this simple manner. And for these patients, we simply need to conclude that there's no result, and we need to stick with the conservative attitude of not adapting treatment based on this. And this slide just to highlight the complexity of the treatment arms that we then add as we zoom in into fine-tuning of treatment and taking into account the stage L2, less than 18 months, no MICN amplification, the presence or absence of life-threatening symptoms, as already mentioned this morning also, that is of course crucially important, and then the array-CGH profile, and then the number of treatment arms that we end up with. So that is of course something that is really important, and I think we will end up with more and more treatment arms, and as we try to create randomized studies, that is something that we need to also bear in mind, that in fact we're having fewer and fewer patients in our different treatment arms, which is important from statistical point of view. The overall success rate in our setting is nearly 80% of genomic profiling in this clinical setting. Other studies, as mentioned previously, are also doing this kind of treatment adaptation based on the genomic profile of the COG study that you already heard about. And in the German group, there's also a study that is going to be stratified here, not on the array-CGH, but expression profiles in this patient group. So one concern that we had was that as we are increasing our technologies and zooming in on what we can pick up as alterations, how does that compare with our classical cohorts? I like to compare this with the CT scans we're doing in patients with Wilms tumor, and in the past when we just did chest X-ray and then we moved on to higher resolution ctDNA, and the eternal question of how to treat with pulmonary micrometastases in Wilms tumor. The question maybe is similar in our setting, looking at the array CGH and now the higher resolution techniques. Are we picking up more alterations, and what is actually happening? But in our setting, in fact, as we move from the techniques that we initially applied, when we first started this in Europe, we were using MLPA, which is a PCR-based technique looking just at some chromosome arms, then array CGH, and moving into SNP arrays. In fact, our classification is still valid, because when we compare the frequencies of numerical versus segmental alterations over the different years, we do not seem to see a significant shift in the different percentages. And I think we have just taken the decision that for smaller alterations that we pick up that are less than 2 megabases, of course there the importance of looking at the constitutional events can only be highlighted, and for some patients where we saw smaller events, indeed we could indicate that these were in fact constitutional events that of course might be of importance also, but then need to be taken into account differently. What about high-risk disease? How can we integrate new biomarkers in the treatment stratification of high-risk disease? And I would like first to highlight a study that I had a pleasure to work on following the INRC working group led by Julie and Dominique, and the work we could do together with John Maris and then Kathleen de Préter, collecting array CGH data from throughout the world in patients with high-risk disease. The initial objective of this work had been to try to identify a copy number signature to distinguish patients who would fail early from disease as compared to long-term survivors. And that was not successful. In fact, there's no single simple array CGH copy number signature that can distinguish these patient populations. But we could learn a number of other things in this patient cohort. Firstly, there is a small subset of patients even in this high-risk disease population with numerical profiles, and these patients do well. Secondly, amongst the high-risk disease, there are some other markers. First, I would like to remind all of you that MYC-N is a member of the MYC family. Sometimes there's not MYC-N amplification, but MYC amplification, as you can see here on chromosome 8q. So we need to remember that this is also a marker of high-risk disease. And in fact, for this patient who had intermediate risk disease, MYC-N amplification should probably be taken into account as MYC-N amplification. So we could indeed show in this paper that other genomic amplifications other than MYC-N are associated with poorer survival, even in this high-risk cohort. And furthermore, that there seems to be a genomic region on chromosome 6q that is also associated with poorer survival. So that is something that we have learned from this disease cohort. Importantly, there has been a nice initiative to make this data available in a common database. I think that is another message to share as we're creating big data sets, sharing of data so that people can interrogate and compare data sets. And what we could see here, Pauline, who worked on this, is that there's a tool where we can interrogate possible prognostic markers. We recently had a patient who in fact had this amplicon on chromosome 19q. So those of you who are also involved in brain tumors know that in this region there's a C19MC miRNA cluster, which is really typically observed in ETMR, the embryonal tumor with multi-layered rosette brain tumors. And when we then went on to look at in our cohort, sorry about this, I need to go back. We can see that there was a small subset of patients with this marker in the high-risk neuroblastoma patients, and these all died of disease. So this gives a possibility to further explore the data. But I would like to also mention that there's also a risk related to this. I think that so far, even though we're in a learning phase, the message is not to adapt treatment and do this outside treatment protocols. So even though we are all desperately in need of looking for new biomarkers, adapting treatment, the main message I think I would like to give is that we need clinical trials and controlled trials as we move towards biomarker-based treatment strategies, and not just do this for one given patient outside trials because there is some data that indicates that. I think that is something that is really important. We have already heard about another biomarker, the TERT rearrangements, published 2 years ago, and the importance of these rearrangements leading to enhancer hijacking on chromosome 5p, and the importance of this event also in terms of survival. Here again, the importance of the prognostic significance in high-risk disease. But what about low and intermediate risk disease? The message is the same. We also recently had a patient who, in fact, as in Rose's message earlier, in the patient group that are termed intermediate risk disease, a patient with localized unresectable disease over 18 months, but this patient actually had a TERT amplification that can nicely be shown here. So we observe these biomarkers, but again, what does it mean? How do we adapt treatment? I think the next step is really to have controlled trials where we take this into account and not just adapt treatment because of the single observations. So what other markers can we use in high-risk disease? A lot of effort has gone into studies of expression profiles with the aim to identify different patient cohorts that might distinguish good versus poor survival, especially in high-risk disease. And different expression profiles have indeed enabled to come up with a distinction of different patient groups. This work that was a collaborative European and COG study work where indeed there seems to be a gene signature based on 59 genes, distinguishing clearly good versus poor survival, especially in low and intermediate risk disease. In high risk disease, however, this does not seem to perform so well. Other studies have looked at miRNA signatures. Again, the same message with regards to the impact on high and low risk disease. And a large number of other studies have based their efforts on the study of these expression signatures. Either on a global evaluation of gene expression or also other studies looking at the microenvironment, macrophage infiltration, etc. However, I think that so far the general message is that these gene expressions are not currently being applied in the clinics. And why is that? I think there are two aspects with regards to that. I think that if we really want to change our current treatment protocols in the high-risk treatment strategy and move on to something else, we need to have strong reasons to leave a treatment strategy that, even though we are not completely satisfied with, we do obtain 50% survival. So I think currently what we need to find are markers that are really significant in terms of distinction of patient subgroups, and secondarily then know what we can do with that. What are we going to change in terms of treatment? And this is where we come to the search for therapeutic targets. How can we integrate the search for therapeutic targets into treatment strategies? Even if we had a signature that identifies patients of very low risk, we would then need to know what we want to do differently. And so a lot of effort has been done on sequencing studies. And you all know this famous graph looking at the number of mutations in neuroblastoma. And we know that in neuroblastoma, there are fewer mutations than in other high-risk adult cancers. However, it is not so as low as some other pediatric cancers as rhabdoid tumors. More recently, there have been two really nice comprehensive sequencing studies published 2 months ago in Nature, one from the German group, one from St. Jude's. And in the paper from the German group, a cohort of around 60 neuroblastoma patients are reported. So here again, we can see the overall number of mutations per megabase in the neuroblastoma patients, which compares to other pediatric cancers. So the mutation rate is not that low. Jan mentioned 10 to 13 mutations per tumor. But what can we do with that? What mutations are we actually looking at? So as already mentioned, there have been a number of sequencing studies looking in detail at that. We know that ALK is the most frequent and most recurrently occurring mutation observed in 8 to 10% of neuroblastoma at the time of diagnosis. And the different studies have highlighted mutations or alterations in genes of the initially termed RAC and RO regulators, the ARID genes, so epigenetic aspects, equally with the ATRSX and PTPN11, and the TERT rearrangements. So we can probably use these mutation profiles to identify neuroblastoma subsets. This will certainly be of importance in the high-risk patient group, and we look very much forward to hearing talks on these subjects within the next few days to learn about how we can add this information on mutation profiles in the general concept of our neuroblastoma patients. More importantly, when we go into detail into these data that was published recently, we can also learn more with regards to mutation signatures. And what the German colleagues did in this paper was look at what has been published as previous mutation signatures based, as already explained this morning, on the types of changes. Are these changes from C to T, C to A, etc.? And in the 10 neuroblastoma samples that were reported, which are down here, in fact, there is no predominance of the signature C to T that can be observed in some other patients. However, there are some cases with what is termed signature 3. Signature 3, which is the yellow one, which is in fact a signature based on mutation and genetic alterations that has been correlated with BRCA-ness kind of phenotype, which can be related to BRCA1 and 2 mutations or other types of alterations, and also a signature 8, which has recently been linked to BRCA2 or PALB2 germline mutations. So these are certainly facts that we will need to look at more in detail and see how we can integrate this into treatment strategies, bearing in mind that BRCA-ness might also possibly be linked to some kind of sensitivity to PARP inhibitors if we think that might be linked in some way. So how can we integrate the mutational profile in treatment strategies? We heard briefly this morning that there's a plan to integrate ALK inhibitors into the frontline treatment in COG, and I think that is hugely important. I think what we would like to do is also have the possibility to integrate other targeted therapies, other TKIs in frontline treatment in high-risk disease based on the mutational profile, but I think we're not there yet. There's a lot of data missing, and firstly, we need to know how many patients would be concerned because we need relevant statistical designs. And I think if we can have a randomized study to look at ALK-targeted treatment, yes or no, in the ALK-mutated patients, that will be something that will be important, and maybe within the other networks, that is something that we could work towards. However, one aspect that is really important when we're looking at the mutational profiles is that these are not static events, and we already heard this morning that the genetic landscape in neuroblastoma changes over time under treatment and maybe even outside treatment based on the genetic heterogeneity. We know that there can be new copy number alterations, that ALK mutations can emerge at the time of relapse. And we know also that when we're looking at the mutations at the time of relapse as compared to diagnosis, we have more mutations in general in this whole genome sequencing collaborative study. The bars on the yellow represent the new relapse mutations, and you can see that there are many more at the time of relapse as compared to diagnosis. And we know that these mutations target specific pathways such as the MAP kinase pathways or other pathways probably also associated with EMT transition. And another publication recently looked at the frequency of targetable mutations in the relapsed neuroblastoma genome, and I think the data from this study is really important because what we can see is the importance, the frequency of targetable mutations at the time of relapse. 58% of patients had targetable alterations at the time of relapse, with again ALK right at the top, TP53, FGFR1, and then a long tail of single events that probably need to be taken into account. So there's been a lot of effort. I would like to finish with 2 words with regards to the efforts that have gone into the molecular characterization of pediatric cancer in general at the time of relapse within what is commonly referred to as precision medicine programs. And there are different initiatives as this throughout the world, some in Europe. I would like to cite the German INFORM program, ITER. There's a UK program soon to start, the French program called MAPI-ACTS, a program in Australia, Zero Childhood Cancer, led by Michelle Haber, and then a number of initiatives in the US and Canada that we also heard about in detail at a recent precision medicine workshop, which was really fascinating and interesting. And there are some neuroblastoma specific trials focusing on this. And so what we can learn from this is the following. I would just like to give information with regards to the French data that we have. So in France, we have the MAPI-ACTS trial that is led by my colleague Birgit Georger. And within this setting, we do new biopsies in high-risk pediatric cancers at the time of relapse. So a new on-purpose biopsy. We do whole exome and RNA-seq sequencing in real time. We discuss the results in a molecular board and then in a clinical board, and all this within 6 weeks to give treatment recommendations to orient treatments towards eSmarts or other relevant clinical trials. And so what we have learned is the following. Amongst the 36 neuroblastoma patients, we have data that can actually be considered as contributive for 28 of these. We desperately need strategies to address these issues in patients where we have relapse only in bone marrow, because sometimes we do not have a primary tumor that can be resampled. And so when we have invaded bone marrow, we have up to 10%, 15% of neuroblastoma cells in a bone marrow, and we need to be able to FACS sort these and enrich and do our molecular analyses on these enriched samples. So what we see is that there are a certain number of targetable alterations if we stick to the very strict definition of one drug, one genetic alteration. And this is just an example of the reports that we get with the multiple alterations, but unfortunately, in this case, no direct target. So I would like to conclude by saying that as we are integrating all these new molecular techniques into the characterization of tumor samples, and I've left out the germline, we're working towards the identification of new prognostic and predictive biomarkers. And I think we need to be clear about the questions we want to ask and how to integrate this into our general global clinical approaches. And I think a lot of what we will hear during the next few days will focus on this. And I think it is hugely important that we set the stage and think about what data can we use for our clinical trials and how can we integrate this. So I like to think about it in different stages. And at diagnosis, I think what we're looking for in low and intermediate risk disease is information that helps us to further fine-tune treatment intensities. In high-risk disease, we desperately need new therapeutic targets to develop new treatment approaches. During the disease course, I think what we need is markers of local and metastatic disease response. I think a lot of work has been done in the MRD setting, and we're also looking forward really to some important talks that we will hear with regards to markers of disease response during treatment. And we want to integrate this and see how we can perhaps modify and change our treatment strategies for high-risk disease. And at the time of relapse, integrate our search for targetable alterations and matched therapies within the context of early clinical trials. So I would like to stop here and thank you for your attention.